All right. So when yesterday we were trying to understand the basic things related down to the fracture appearance on a radiology. So today we will try to learn more about recognition of a fracture and then try to recognition of dislocations and subluxations and try to describe the fractures according to their uh, the number of fragments, types of fracture lines and relationship of the fragments to each other, right? And relation down to the atmosphere, and then we will see some common fractures, and then finally we will go up with fracture healing. You know, you have to understand one thing here, that it doesn't matter what kind of a fracture it is, doesn't matter what part of the body has a fracture, generally part of a bone has a fracture, all of the fractures actually appears as the same thing. Okay, the basic appearance of a fracture can be defined as the discontinuity in the part of the cortex or the periosteum of a bone. Okay, that's how it is. So fracture on radiology looks like a hyperlucent or a black line, suggesting the discontinuity in the cortex or the part of the bone. So that is how a fracture is. So again, like, doesn't matter which part of the bone or which bone has a fracture, it looks the same all over. Okay, so radiographic features generally do not change, but the anatomical relation changes, the characteristic of the fracture changes accordingly, depending upon the classification. So to understand this, okay, to basic understanding of the fracture mechanism, somebody actually needs to find out the evidences from the forensic medicine. Okay, since last time you told me that you haven't learned such things in forensic medicine, there are certain parts of the forensic medicine. Okay, my voice is not clear right now. Is it clear now? What is so much? It's clear. Clear or not clear? It's noisy? Yeah, I did mute others. Yes, yes, I did. No, because I can't hear other guys, so that's the reason. Right. Okay. So yesterday I was telling you that you need to understand the action dynamics when it is related down to any kind of an accident, right? See, since fractures, the main important reason related down to the fractures is fractures related down to the fractures is uh, always related down to the action that has happened at the nick of the moment, right? So such kind of analysis that is related down to any kind of an accident is actually called as an accident analysis. Okay, or there are also some sectors in the forensic medicine, we call them as crime scene investigation. Generally this is not a crime scene investigation, but you can actually call it as accident analysis investigation. Okay, you actually call it as debugging. Okay, you call it as debugging, trying to find out all the evidences, which how the accident have started, how the accident have ended, and where are the people could have been, where are they stuck or something like that. It can also happen in road traffic accident analysis as well. So, as a basic physicians, we should be at least a relatively a little aware of such kind of action dynamics, so that we can actually understand and try to get diagnosed more. For example, to say, let us imagine a person with 30 years old who has been riding on a bike. Okay, have you completed this road traffic accident section in forensic medicine? Yes. Okay. I think you know about road traffic accidents, right? Then, okay. Then let me give you a case scenario and let us try to analyze it. Okay. A 30 years old male has been riding on a bike. Okay, and he has been going on the wrong lane. So a a car comes from the opposite side, and the person, actually the biker, rides at something around like 60 miles per hour. Okay, he was on a highway. Okay, don't ask me why he rides 60 miles per hour on a road. Okay, so he was on a highway, and he's riding it 60 miles per hour, something around like 90 kilometers per hour. Okay, and the opposite truck opposite truck is coming something around like 40 miles per hour. All right. So right now they had a head on end collision. Okay, I think you heard this term, head on end. Sorry, head on head. This is head on head collision. Okay, right. So now, can you estimate? Okay, they are coming down in straight lines. All right, both of them are coming down in straight lines. Okay, and they had head on head collision. And can you now estimate and tell me what bones of this biker could have fractured? Okay, that is what, when you try to analyze a person like this is actually called as road traffic accident analysis. All right. Uh, anybody from, well, let's say he's wearing helmet. Let's say he's wearing helmet. Other than that, nothing else. See, analysis of this one, okay, analysis of this kind of an accident actually requires a lot of understanding of the, action dynamics, okay, the dynamics of physical things, okay, the physical laws apply here, and also the anatomy applies here, okay, the force, the thrust, okay, the thrust of injury, the force of injury, okay, the speed of collision, all of them comes down into action, right? So studying of all these things and estimating the risk of injuries in this kind of person is actually called as action dynamics. Okay, that is what you need to understand here. Well, let me give you another scenario. Let us imagine that you were standing up in a street. Well, and there has been this terrorist organization, okay, who has put up a bomb in some kind of a restaurant, which actually happens a lot in Hyderabad. Okay. Well, I mean, in India. Well, and then, what happened is that it was, 1 ton sorry, 1 kilo RDX, and which has got in impact something around like 500 meters all over the place. Then, and finally, there are over 100 people that have been injured. Okay, and right now the emergency teams have come over. Okay, the paramedics have come over. Right now they are going to classify the patients or the victims based on a system that is actually called as triage. Okay, I think you know about triage. You heard about the name triage, right? Right now, how does actually the okay, triage is an emergency disaster management protocol. Okay, whenever some kind of an accident happens, okay, even on the road, even in the hospital, or even when an epidemic outbreak or a pandemic happens, okay, everybody is actually changed, relocated from their positions. I think you heard recently we had a gas leak accident in India, right? That there was this, the polyvinyl chloride factory has been having a gas leakage in Vishakhapatnam, right? It's a port city. And when you are actually trying to do this one, whenever you are trying to analyze the such kind of a situation, the paramedic teams and the emergency physicians actually try to classify the patients according to the injuries that have happened. Okay, uh, they classify them as three colors. Okay, the red, the yellow, and the black or the white. Okay, So it is actually called as the triage classification. I think you will learn this in epidemiology and public health medicine if you have studied it already. Maybe if you haven't studied about this, better you try to learn about this triage classification. It's a very, very important topic to learn for the doctors in clinical practice. Okay, so triage system. The same thing happened down after Hiroshima Nagasaki explosion. The same thing happened after Chernobyl disaster in Russia, and then the same thing happened down after Bhopal gas tragedy, and the same thing happened down in Vizag tragedy recently. Well, so whenever there is some kind of a bombings or happening, the emergency physicians and the paramedics actually try to classify the patients based upon their injuries and fractures. Okay, so how do we actually do that? So for that kind of understanding, there is a classification. There is one some kind of a classification that is actually called as the Gustilo Anderson classification. Okay, it is actually called as Gustilo Anderson classification of injuries. Okay, right? Gustilo Anderson classification of injuries. All right. So try to remember this name. Okay, it is just you need to just remember this name. If somebody interested, yes, they can go and read down in the forensics chapters. Yes, you can actually find it out all this there, the classification of fractures and how they happen, the actions happen, how to suspect what other fractures can be present down in the person who has met up with an accident or a ballistic injury or a gunshot. Okay, or if there is some kind of a mob fight, gang wars. Okay, all these kinds of classification can be learned in forensic medicine. Actually, your teacher should have taught you about that one, but if she didn't teach, well, maybe you should spend some time to learn about that. Well, that is a different part of the story. But right now, actually, doesn't matter what kind of injury it is, it always looks like the disruption in the continuity of a part of a bone, right? Okay, so how do we recognize it? It can be recognized if the cortex is broken through and it is called as the fracture is complete. So for example, to say the lateral edge of a bone to the next lateral edge, okay, or let us say from the medial edge to the lateral edge, if the fracture is seen, it is actually called as a complete fracture. Okay, remember, I will show you the pictures, but first try to understand this one. From the medial edge to the lateral edge, okay, if it is broken, that is called as a complete fracture. Well, only if there is some part of a cortex is broken, it is actually called as an incomplete fracture. So how can a fracture be classified? A fracture can be classified only as a part of a bone broken, it is as incomplete fracture, or if the cortex of bone broken from medial edge to the lateral edge, it is actually called as a complete fracture. Okay? So understand this one thing. It takes a lot of power to actually have a complete fracture. Okay, a lot of force has to be present. For example, to say in forensics, you will actually try to learn which part of the body requires how much amount of force. For example, to say the chest. Actually, somebody was telling me yesterday that sternum is the most common organ to have a liable fracture, and somebody was saying clavicle, right? Both of your answers are wrong. Actually, it takes something around like 60 pounds of force to break the sternum. Okay, it takes a 60 pounds of force to break the sternum, and something around like 20 to 30 pounds of force to break down the clavicle. Okay, and falling that amount of weight has to fall from something around like you know from a 2 meters height. Yes, it will obviously break down the clavicle. Okay, a direct impact on a sternum, something around like 60 pounds of force with a direct impact on a sternum actually breaks it. And a 20 pound or something around like 10 pound to 20 pound of force falling from a height of 2 meters will actually cause the clavicle injury, right? So the classification actually depends, the complete classification or incomplete fracture classification actually happens and depends upon the amount of force. Okay, but however, you need to understand this is when it is related down to the action dynamics. But actually, there are some kinds of diseases which can also cause an incomplete fracture. In that one, you have to understand a very, very important disease which is also known as the Paget's disease. Okay, remember Paget's disease. All right, this one is one of the most important types of a disease that actually causes incomplete fractures where the bones are softer than normal, especially in the children or sometimes in adults, which is a bone softening disease. Okay, have you ever heard this term, which is called as a Paget's disease? Okay, Paget's disease, right? Do not confuse it with the Paget's disease in gynecology. Okay, there is another disease that is actually called as the Paget's disease of the breast. Okay, do not confuse that one with this one. This is in orthopedics. That one is in gynecology. Okay, have you ever heard this? Right? Have you ever heard this name, pudy orange breasts? Okay, that is actually known as the Paget's disease in gynecology. All right. So that Paget's disease is different from this Paget's disease. Okay, this Paget's disease is related down to bones. All right. So Paget's disease is a bone softening, disease where actually there is overhealing of the, bones. All right. Whenever there has been an injury, there will be overhealing of the bones, and actually the bones become so brittle, so these people are more liable to actually have large amounts of fractures. All right. So have you ever heard of a disease that is actually called as osteogenic imperfecta? Okay. Well, that one is actually causing a lot of dislocations. No, no, no. Osteogenic imperfecta is not exactly an old age disease. Okay, it is it's a congenital disease where the joints actually are completely very flexible. All right. I think maybe in YouTube you have watched some people actually twisting their body, right? I think I have watched this very famous African guy who can actually, completely twist his body, right? Fragile bones. Yes, osteogenic imperfecta, having fragile bones and fragile joints. All right, flexible joints, you can say, not actually fragile joints, flexible joints and fragile bones. Okay, so those people are actually, it happens mostly in children. Paget's disease happens mostly in children, and in such kind of diseases, only a part of a cortex is actually uh, break. Right now, you see here, you have to understand one kind of a colloquial term that if there is an incomplete fracture without breaking of the cortex from one end to the other end, in children, it is generally known as the green stick fracture. Okay, remember, green stick fractures especially occurs in children, okay, which involves only one part of the cortex of the bone. All right, but you have to understand there is another fracture that is actually called as the torus fracture or the buccal fracture, which is actually called as the compression of the cortex. You see here, incomplete fracture has the cortex involvation. Okay, cortex is involved, but it is not compressed. But buccal fracture, okay, is the one, or the torus fracture is the one that there is the compression of the cortex, and there will be invagination of the one part of the bone into another part of the bone. Okay, so that is actually called as the buccal fractures. Okay, we will see the pictures, we will try to understand them. Okay, remember there are two types of fractures. One is a complete fracture where the cortex is completely broken from one edge to the other edge. Generally, you can define it as the lateral edge to the medial edge. Then there is only a part of a cortex that is actually broken. It is incomplete in nature. And it is also known as the green stick fracture if it is occurring in children in kind of situations like Pagets disease. But there is another fracture that is known as the torus fracture or the buccal fracture, which actually represents the compression of the cortex and the invagination of one part of the bone into the other part of the bone. Okay, right. So now you see here, let's try to understand this a buccal fracture and a green stick fracture. You see here, the incomplete fractures are the ones that actually involve only the portion of a cortex, right? And become they tend to occur more in softer than normal, and then in the children or generally in adults where such kind of a disease called as a Paget's disease. So you see here in this x-ray, I am able to look, okay, I am able to look that there is this the radial uh, lateral edge has been fractured, where there I can see that the complete destruction of the cortex has happened. But you see here the medial edge of the radius is not destroyed. It is completely remaining intact, where I can see only one edge of the cortex, but still it is actually called as a fracture. You see here, this is actually called as a green stick fracture. See, all the cortex has not been involved. Okay, this cortex and all the other opposite cortex is not involved, which means to say there is only the breakage of bone from one side. All right. So, for example, to say as if you are crushing the tin, the Coke tin only on one side rather than other side is completely intact. Okay, the Coke tin is cylindrical in nature, right? Even the bones are cylindrical in nature. So when you are trying to compress the tin only from one side, the other side actually remains intact, right? So that's the same thing actually happens down in a green stick fracture as well. All right. Okay, so remember the classification of a green stick fracture from a buccal fracture is actually based upon involvement of the cortex, all right, and also the position of the cortex into the other part of the bone. So that is how you are actually going to find it out. And you have to make sure that you understand this, because analysis of fracture radiology is the only way. Okay, only X-rays are able to tell you how much severity of the fracture has happened. Okay, so without radiology, you cannot diagnose a fracture. So make sure that you learn these chapters very, very well for your clinical practice. All right. So in this part here, there is only involvement of only one side of the cortex. All right. So such kind of a fracture is actually called as a green stick fracture. It is called as a green stick fracture just the reason when you are actually trying to break a twig or a branch, a green colored twig or a branch, which is technically having a lot of fibrous material in them, you cannot completely break it, right? So it will actually break on only one side, but the other side actually remains intact and it keeps connected to the tree, right? So that is the reason you actually call it as a green stick fracture when you are trying to break a green stick. So that is how the action dynamic is also happening in the bones. That's the reason it is actually called as a green stick fracture. So green stick fracture generally occurs in children. Remember that one. You see here, why I stress you a lot like this, because radius and ulna are the most common regions in children who will have a green stick fracture. Okay, radius, children are the one who actually walks a lot. Okay, when the baby starts to keep walking, okay, let us say the baby actually try to climb the stairs. When the baby is try to when the baby starts walking at the age of 1 year, and then he slowly starts getting down, getting onto the stairs, he will be able, rather than crawling right now, he will be walking on his two legs, right? So whenever the baby is actually trying to fall from a height, Okay, so let us say if the baby is trying to climb up on the stairs and baby is trying to stand on one of the steps. Right now, what actually happens is that baby has actually, slipped because he was not unaware of the surroundings. So when he's slipping, actually he's trying to protect himself, right? This is a natural phenomenon. Okay, you need not teach a baby to put up hands in front while he's falling. It is an initial response which is already pre-designed in your brain. Okay, that is immediately after you are born. Okay, such kind of reflexes are activated immediately after the time you are born. All right. You will learn that in pediatrics, though. What are the reflexes that which one will be activated at what time of age? Okay. So this one is already activated, and right now the baby is trying to prevent the fall. At that point of time, the baby's hand is already brittle. Okay. And yes, it might cause a green stick fracture depending upon the height he is falling up. Okay. Well, stickies, generally you do not try to do such kind of treatment no more, Aman. Okay? Stickies tied on the forearm and then bandage is tied around the forearm, it actually depends on the, expansion of the fracture. Okay? We'll not talk about the treatment here. Okay? You saw it when you are small, actually, because I think you have seen some kind of a local village doctor doing that one. But no, orthopedicians generally do not do it that way. No, it's changed. It's changed. When you were small, it is 20 years ago. When I was small, it is something around like 30 years ago. Okay? So do not try to remember that what happens in a village. Okay? They are wrong. We'll talk about when we are coming down to the complications of the fractures. You brought up a very good point. Yes, we will be learning it in radiology about the complications of a fracture in this chapter as well. Okay, now you see here, but you look at the when compared to the other image here, when there is a part of a cortex that has been broken, look at this one, which is actually called as a buccal fracture. You see here, the cortex is actually still intact, but only there is a disruption of a mild part of the cortex, which actually causing an external buckling. Okay, when you are trying to remove a part of a green stick, okay, that actually becomes buckled. Okay, when a single layer of a green stick is plucked out, it is actually called as the buckling. All right, so this one is actually called as a torus fracture, and I can technically say that this is a child. Okay, this is a child. Okay, can you guys guess the age? Can you try to guess the age of this person? How can you say it, Aman? Okay, well, maybe I will not make it pretty much detailed. First, let's complete the chapter. Okay, does everybody know what are the carpal bones are here? Okay, the age classification on the bones is generally done, okay, according to the number of carpals that have been ossified. Okay, right? You can see here that this one, actually the pisiform bone is actually not yet formed. Okay, the pisiform bone has not yet been formed, so that's the reason I can actually say that this is less than 7 years. Okay, this baby is less than 7 years, because after 7 years your pisiform bone is going to completely ossify. All right, and then I can see the scaphoid and the lunate and the capitate and the hamate. All right, this is the tracheostrum and the trapezium and the trapezium and the trapezoid and capitate and hamate bones are actually seen. So that's the reason actually they are ossified below the age of 5 years. And the pisiform bone generally gets ossified at the age of 7 years or something. So you can actually say that this baby is less than something around like 5 years. Okay, something around like 5 years. That is how we actually try to guess the age of a person. But it is not worried about that one. And also, you see here, this one is the metacarpal bone, right? This is the metacarpal bone, and this is the actually the thumb, act, which hasn't been ossified yet. Okay, you see here, this is the epiphysis of the thumb, and this is the metaphysis of the thumb. Okay, of the first phalanx. All right, I'm looking at the metacarpal of the thumb. All right, the metacarpal of the thumb, which hasn't been joined with the corresponding carpal yet. So, and you can also see that there has been no ossification inside the within the metacarpal of this bone here. So by this also I can say that this is a child of less than 5 years. All right, something around like 5 years. And you can see here, so since this was a child, you can actually see that there has been expansion of this cortex, okay, which is actually called as a buccal fracture because it is buckling out. Okay, the buckling of the cortex is actually called as the buccal fracture. The other name for it is a torus fracture. So can you understand this classification here? Difference between a green stick fracture and a buccal fracture? Is this part clear? Yes, right? And you see here, I tell you, I stress out this one very, very like this because let's say maybe in your 2014 batch students, they had a problem, something like this. Okay, since they were copying a lot, I'll tell you a secret, okay, how I can actually make you guys feel scared. Okay, this is not scary story, but still you have to understand why it is really very important in a clinical practice, understanding this. The thing is that, okay, let us say if I gave a history that, okay, a person of 3 years old baby, okay, or 3 years old child has had an x-ray, something like this, and I wanted you to diagnose, okay, and you call it as a green stick fracture, obviously, right? But when I make it something around like 60-year-old female coming out with an x-ray, something like this, the diagnosis is entirely different. Did you understand it? Okay. The diagnosis will be entirely different. It is actually called as a Cooleys fracture there. Okay. Cooleys fracture is also appears something like this, but you actually, the x-ray almost looks same like this. But if it is happening in a child, we call it as a green stick fracture. If it is happening in the adult and greater than 50 years of age, we are actually calling it as a Cooleys fracture. So it is happening in the radius and the ulna. Okay, so we will learn about that one, about the names of fractures when we are looking at the classification of fractures. So you see here, just giving out the same kind of history with the same kind of action dynamics description, I just changed the age of the person, the diagnosis is changed, the x-ray appearance remains the same. Did you understand this one? So please do not make a mistake like this. Okay, right? Okay, green stick fractures generally involves only one end of the cortex. That's it. Actually, why I'm talking about the 2014 batch guys is that they had been very clever and they have been preparing all the old question papers. So what we did is just change the age. I removed one of the zero and I changed and I gave 6. Okay, before it was a 60-year-old male, but right now I put it as a 6-year-old male. The diagnosis was changed. The case was completely wrong. Everybody started to write green stick fracture, sorry, Cooley's fracture, but the answer was green stick fracture. All right. So, and they lost 20 marks. Okay. The highest that year was something around like, 71, I guess. All right. So please do not make a mistake like that. So just changing down a single number with the same history, same pictures would change you entire story. Okay. But in clinical practice, you are going to be wrong and you are going to get a wrong treatment. That's why I'm telling you that you have to understand these ones. All right. It is not about the marks, though. It is not, but you don't confuse yourselves with the different types of fractures. So that's the reason. Understand this one. And yes, you will be having a case sheet from skeletal system. All right. So, and yeah, it could most probably be a fracture with complications. All right. So learn this chapter well. Well, characteristics of an acute fracture. Okay, you have to understand. Okay, can you tell me what is called as an acute fracture and what is called as a chronic fracture? Have you completed the healing factors of healing or inflammation? Okay, healing of inflammation in pathology section. Okay, if you have learned that one, yeah, you can answer this question. What is an acute fracture? Somebody? Acute is. Are you talking about are you talking about inflammation here? No, no. I'm talking about a fracture. Okay, particularly, not exactly about inflammation, but because while you are learning about the factors of healing, you will be also learning about the fractures at that point of time. So that's the reason I'm asking it here. Well, you see here, any kind of a critical breaking happening is actually called as a fracture. But you have to understand that the healing of the fracture is actually done by which one? Osteoblasts, right? So if the osteoblasts are coming down, actually it comes down after fifth day after the time the fracture has taken. So less than 5 days, okay, 3 to 5 days is actually called as an acute fracture. And generally, after if it has been passed down after 7 days, you call it as a chronic fracture, right? Because after 7 days, the healing will be started and ossification centers start to appear, and ossification or the bone repair start to commence. All right. So when the bone healing has already started, and the fracture is will not be completely healed. So the fractures will heal incompletely, and the broken bone contracture will be the same way like the fracture happened, like the time when the fracture has happened. So the bones will heal in bent positions. Okay. So such kind of a problems will actually happen. We will learn that in fracture healing mechanisms, but still you have to understand that any kind of a person who is having an acute fracture has to be treated in less than 5 days. Okay, after 5 days you cannot heal the fracture. You cannot actually correct the fracture with the bandages and the plaster of paris cast. All right. So that's the reason I'm telling you, you have to learn about the acute fracture characteristics. So, what are the acute fracture characteristics? Abrupt disruption of all or a part of a cortex. Okay. So, which actually determines if it is a complete fracture or an incomplete fracture. That is there. A fracture line should be present. The first thing. Then you actually have to see that there are acute changes in the smooth contour of a normal bone. Okay, so smooth contour of a normal bone will be lost. Actually, the surroundings of tissues will actually, if there is an inflammation. You see here, clinically, a fracture can be recognized immediately. Whenever you had a fracture, there will be increased sudden swelling, right? Okay, immediately after you have a fracture, there will be a lot of edematic fluid that is coming down into this region of the fracture, right? So there is a lot of swelling, there will be a lot of pain. Okay, the pain is completely very sharp and it is osteopathic in nature. And then there will be a lot of swelling because of the local edema. Okay, the edema is non-pitting edema, and then it will turn out red. It will increase in the temperature because all the cells of healing have been activated, right? So all the signs of acute inflammation will come down in a case of a fracture, and those things will be evident down on X-ray, where the acute changes in the smooth muscles are in these soft tissue structures will be changed. Okay, so it will be there, and then fracture lines are hyperlucent. All right, fracture lines are black in nature. They are uh, hypodense, and they are in straight lines. Okay, it doesn't matter what kind of a straight line it is. Okay, even it can be arced, it can be curved, but still it most of these fractures will actually be linear. Okay, and remember, it appears as a black line. Okay, and then not at the ossification centers, remember that one. Okay, fractures need to appear mostly at the below the diaphysis, sorry, uh, below the metaphysis and above the diaphysis. Okay, generally it can happen on the shaft. Okay, and where the fracture line change their course, they tend to become sharply angulated. Okay, remember a very important point: when the fracture line is actually extending from one edge to the other edge, they become angulated, and the angulated edges are very sharp. Okay, then the fracture fragments are jagged and not corticated. Okay, right? The fracture fragments will be jagged in the sense, okay, they will be scattered all over the place, and they are not corticated. Corticated in the sense they will not have the cortical distribution, right? Then now you see here, let's try to analyze this one. Now, whenever you see some kind of a black line on an X-ray, okay, when you see a black line on an X-ray, you have to make sure to classify it from the nutrient canal. Okay, every bone, every long bone, doesn't matter how big it is or how small it is. Okay, even the phalanges, okay, the distal phalanges are also called as long bones. Yes or no? Right? The ones which are having the cylindrical structure are actually called as the long bones. So every kind of a long bone has a nutrient artery entering into them. Yes or no? Have you heard this? Okay, nutrient artery, right? Nutrient artery actually enters from the along the generally along the upper third, or generally along the midway of the any kind of a long bone. You see here, and that nutrient artery is actually canalizing along the cavity of the bone, right? So it is the in such part actually generally there will be no trabeculae, and that one also appears down as a black line. Okay, now you look at this image and you tell me if this is a fracture where the arrows are pointed, or if this is a nutrient canal. Okay, when you look at this image, you tell me if this is a nutrient canal or if this is a fracture. You see, can you see it in a zoomed way? Okay, can you see it? Can you see me magnifying it? Okay, okay, you cannot see it. Okay, just give me a second then. Okay, can you see now? Okay, you look at this one, you see here there is a very black line. Okay, there is a hyperlucent line that has been extending from the upper let us say distal metaphysis and coming down into the mid diaphysis. Okay, there is a translucent or a radiolucent line that has been extending from the center of the bone to the cortex, or you can say from the cortex to the center of the bone along the uh, distal end of the let us say this one is the fourth metatarsal, metacarpal. Okay, So is this a fracture or this is a nutrient canal? Okay, is this a fracture or a nutrient canal? Is everybody attentive? Okay, it is a nutrient canal. You have to understand one thing. Okay, every long bone has got some kind of an arrangement of a nutrient canal. Okay, you should know the distribution of the nutrient canal, but still, generally you see here you can actually misdiagnose this one. So how can I actually recognize and differentiate it from a fracture? You see here the nutrient canal will not have the discontinuity of the cortex. The cortex keeps continuous, okay, on the other sides, and right, then there will be no other secondary signs of the fracture, just what we saw in this uh, in this slide. All right, so a nutrient canal generally will not have the disruption of the cortex, and there will be the better orientation of the cortex. Okay, and all other structures actually remain intact. By that you can actually understand it is actually a nutrient canal. And such kind of problem generally happens when you are actually changing the view of the bone. Okay, when you are actually trying to move it in the oblique views. Okay, generally this one is actually the oblique view of the hand. Okay, so a different view of the hand or a different view of a bone will are likely to give out a shadow of a nutrient canal. Okay, so but how does actually a fracture look like? You see here, you can clearly define this one is not a nuclear. This is one is not a nutrient canal, and you can see that the edges are quite sharp where the line of the fracture has happened. Can you appreciate this one? You see here, this edge is actually much more sharper, right? So, but even though it actually appears down as the nutrient canal, but it is not a nutrient canal because the edges are quite sharp and there is a complete disruption or the discontinuity in the cortex. So that is how you are actually differentiating if it is a nutrient canal or if it's a fracture. Okay. Yes, this is a complete fracture. That's correct. Okay, this is a complete fracture. Can you tell me which number phalanx is this one? Is Reshma here? Yes. Okay, can you tell me? Yesterday you are the one, I guess you are the one who is mistaken, right? Can you tell me which one? If it's the third, first, second, which one? Why everybody is saying it third? Okay, at least some hand. Which hand? So is the ring finger, okay? Is the ring finger the third or the fourth? Fourth. So why everybody starts keeping saying it as the third now, right? So I guess you haven't, learned about. Of course, you have to include the thumb. Why are you excluding the thumb in this scenario? Okay. So this is the first. Okay, is this a carpal or a metacarpal? Is this a carpal or a metacarpal? Okay, it's a metacarpal. Okay, is it the proximal metacarpal or the distal metacarpal? Your answer is wrong. It's not a metacarpal. It's the phalanx. Metacarpals are present down here. You see here, these are the metacarpals. Okay, this one is the phalanx. So there is a fourth phalanx proximal bone fracture. Yes or no? The proximal phalanx of the fourth finger has been fractured, right? All of you guys are not even listening. Nobody is. When I asked you a question, okay, if this is a carpal or a metacarpal, I'm just asking you and expecting an answer. You have to tell me, sir, you are not talking about the phalanx. Don't answer. Only choose from carpal or metacarpal. Okay? Why can't you correct me? I intentionally did it. Okay? I want you to think about it if you are looking at the carpal or the metacarpal or if you are looking at the phalanges. All right? So it is the proximal phalanx which has been fractured, and that is number 4. All right? So it is not a metacarpal or a carpal. Understand? So next time you can correct it. If it is not seen in the options, doesn't mean to say you can understand I'm trying to bluff you. Okay, you see here, generally such kind of fractures might happen, doesn't matter, when there is a stone pelting or when there is some kind of a blunt force injury that has a direct impact onto this phalanx. Okay, depends. There are so many conditions. Okay, a direct injury, for example, to say maybe a weight has fallen upon him. Okay, right? Or he has hit with a rod at only at that point of time. Okay, most of the times blunt force injuries actually happens. You see here, how can I actually recognize it? I can actually recognize there is a swelling of the soft tissue, and you see here there is a disruption of the smoothness of the soft tissue here, first thing. Then I'm going to look that there is a radiolucent line that is present. There is a disruption of the cortex, so I can recognize it as first I'm suspecting a fracture. Then I can confirm by the smoothness loss of contour along the soft tissue edges, and then I'm looking at the sharpness of the fracture edges. So that one will actually confirm me. No, machines will actually cause crush injury. Okay, this is not crush injury. Okay, machines actually causes crush injury. There will be complete disruption of all the phalanges and the metacarpals in such place. Okay, this one actually something like a big stone has fallen down on his finger, or somebody hit that finger with a rod. When somebody is trying to hit, he is actually trying to protect his just with the finger. Okay, so forceful injury, a blunt injury has to happen. All right. Okay, with a thin object, generally a stone or a weight. Okay, that's fine. Right. So this is how I know to be it is as a fracture. And you see here the edges of the fractures are jagged and rough. You see here these edges are completely jagged and rough. All right. Now you see here there are other types of fractures which you need to be able to classify it from the normal ossification lines. Okay, that is also very important. And you see here this one is the epiphysis, right? And this is the epiphyseal plate, and this is the epiphyseal line, which is again appearing down as the radiolucent line itself. Okay, this one is a child, and the one I'm looking at is the left humerus. Okay, I'm looking at the x-ray that has been taken down is the left shoulder joint. Okay, glenohumeral joint, because I can recognize the acromion process and the coracoid processes here. Okay, acromion process and the coracoid process, acromion, coracoid. Okay, and I'm looking at the glenoid capsule here, and this is the left shoulder. I can know that this is the left shoulder because the glenoid capsule is present onto the right. So glenoid capsule is open onto the lateral side. So this one is a left side. Did you understand how I recognize this one? Did you understand this anatomy? Yes, of course, it is the right thing. Yes, the other hand X-ray is the right. That's true. Okay. So you see here, you have to make sure You see here, I am looking at the shoulder joint. The first thing, first you actually try to classify the region. Okay, this is a shoulder joint. All right. How can I actually recognize this is if this is the right one or if this is the left one? Okay. Once I make sure that this is the shoulder joint, okay, you see here the glenoid capsule, the glenoid tubercle is the one that is actually present down onto my right side. Okay, the glenoid capsule is present onto my right side, opening down onto the right side. This is the head of the humerus, and this is the opening of the glenoid capsule, right? Okay, this is the one that is actually forming the joint, right? And then which side it will be open? It is always open onto the lateral side. Now this glenoid capsule is present onto my right side, which means to say the opposite hand I'm looking at. So I'm looking at the left shoulder joint. Is it easy now, Reshma? Right? So you have to make sure which kind of joint you are looking at. Because I tell you, most of the doctors actually make this kind of a mistake, holding the x-ray on the reverse side. If you are just changing it on the reverse side, you are completely mistaking it as the opposite side of the body. So please make sure that you are looking at the labels that are present down on the x-ray. Okay. Well, I haven't come down into the fracture part yet, Benedict. First, I'm trying to teach you how to learn about the sites. Yes, and you can also, once you have learned about the site, you start looking about the what are the radiolucent lines that are present. You see here, which if the observation of the radiolucent lines actually tells you about the age. So you are trying to make sure that if you are looking at a child, or if you are looking at an adult, or if you are looking at a geriatric patient, so making sure what are the normal parts of the bone are. Okay, that is the next step. So in this x-ray, once I came to understand that I'm looking at the left shoulder, I am try to analyze if I'm looking at the child or if it is an adult. All right, because the humerus has got the ossification centers. Okay, the ossification of the humerus generally happens after 10 years. So, and the metaphysis you see here, the ossification generally already had started, and you can see here there are hyperlucent lines along the metaphysis. Okay, this is the epiphysis and this is the metaphysis. Just above the metaphysis I can see a very very thin radiolucent line that is extending, and you can see in the other side also I can see that there is an apophysis which hasn't been ossified yet. So this is continuous like this. Do you understand? This is continuous like this. So if this is continuous like this, actually I can understand that I am indeed looking at the epiphyseal line, and this hyperlucent or these white lines that I see here are the epiphyseal plates. Okay, is this clear, Benedict? All other guys, is this clear? What I'm looking at is, first I'm making sure if I'm looking at the ossification centers or if I'm looking at a fracture. Okay, that is first you are trying to do. And you see here the edge of this one is actually continuous one, and this is obviously a child because the ossification centers are continuous along with the epiphyseal lines. So I'm looking at a child whose ossifications aren't complete yet. So I make sure that this is not a fracture. But if it could have been a fracture, you see here, it should look like this along the black arrow. You see here, any kind of a fracture will have an irregular edge, but an epiphyseal line will not have an irregular edge. It will be continuous and it will maintain technically a shape with a blurring edge. But you see here, even the edges are blurred here, but they become actually angulated. So this one became a fracture. Can somebody tell me if this is a complete fracture or an incomplete fracture? Why does Debelina think it's an incomplete fracture? Oh, sorry. Why does Debelina think it's a complete fracture? Because it is not a complete fracture because the other cortex is completely intact. Or is it incomplete fracture? You see here, all the people who have been telling it is an incomplete fracture, you guys are not looking closely. You are forgetting the rules of observation. What is the rule of observation? Okay. 从内侧到外侧 medial to lateral. Okay. See, the thing is that actually, what actually happens here is that you look here, this is a complete fracture. The reason why it is a complete fracture is that you are trying to ignore the cortex orientation on the medial side. Look closely here. There is a discontinuation of the cortex along this place as a thin edge. Can you recognize it? Can everybody see the closeness? Let me share it up with the um, magnifier again. Just a second. See here, this one. Can you see where the mouse is pointed? Can you see the disruption of the cortex here? Yes or no? See, there is some mild black line that is actually coming, and this is actually indicating that this side the cortex has also been disrupted. Yes or no? Did you understand? Yes. So, which means to say the medial edge has also been disrupted. So this is a complete fracture. So Dabelina, were you able to make this analysis or you just had hit a hard? Just chose from two options called as a complete or incomplete fracture, right? No, were you able to make this kind of analysis? All the people who has done as incomplete fracture, you are not looking at the x-ray closely. And also you are forgetting the rule. The rule of x-rays is that you actually have to look at the two different views. Nobody even asked me a question, sir, how does it actually look like on the lateral side? So you are trying to make a conclusion based on just this one. So don't do that kind of mistake. So you understand why I told you the rules of observation yesterday. So you see here, this one is talking about the classification of the epiphyseal plates and classification of a fracture. So Benedict, is this point clear now? How can you actually differentiate between the epiphyseal plates and the fractures? And you have to also understand that most of the fractures generally happen along the distal edges. Okay, proximal edge fractures also happens. Okay, most of the times, yes, the fractures happens along the distal ends of the bones. Generally, but not standardly, but generally they happen along the distal fractures of the bone. When you are trying to understand these kinds and differentiating it from the shaft epiphysis or the metaphysis and the diaphysis, there is a classification that is actually called as Salter-Harris classification. Salter-Harris classification of fractures. Okay, we will learn this one today. Okay, Salter-Harris classification of fractures. This one will actually help you to recognize if the fractures have happened down in the epiphysis, metaphysis, and the diaphysis as well. Okay, so in using this kind of classification and observation method, you can actually recognize if the fractures have happened in the epiphysis, if the fractures have happened in the metaphysis and other things. Okay, so that we will learn, but you still understand here what I'm looking at is the epiphyseal line and this is the fracture. Okay, right? So now how can I actually see that there are three kinds of pitfalls? Pitfalls in the sense that this one actually will try to let you misdiagnose the condition. The pitfalls are actually that there are sesamoid bone presences. Okay, there is a sesamoid bone. Okay, a sesamoid bone is a bone that actually forms in a tendon as it passes over the joint. So the best example of a sesamoid bone is the patella. Okay, well, I think in anatomy you should have learned that the sesamoid bone actually a vestigial organ. Have you heard this in your anatomy class? They say that okay, patella has got no particular function. Okay, yes, okay. Well, you're Benedict. You can recognize the detachment of the cartilage. See, obviously the cartilage is nothing but the one that is actually differentiating your epiphysis and metaphysis. Cartilage is a soft tissue and it is not shown upon an X-ray. Okay, so how can you actually say that the detachment of the cartilage from a bone? Yes, MRI is the correct study. Yes, Benedict. Unless and until there is a complete disruption of the cartilage, there should be a lot of inflammation. Generally, where are the cartilages? Cartilages are present along the joint edges, right? Where the both joints meet. Okay, glenoid has got the glenoid capsule, humerus has got the humerus head capsule, right? So that one is the cartilaginous covering, right? So whenever, let us say, if the cartilage has been disrupted, there should be a lot of inflammation signs that should be present along the glenohumeral joint space. So now in this image along the glenohumeral joint space, can you see that inflammatory signs? Hyperdensity, a lot of soft tissue swelling is there, or is there any disruption of the edges of along the humeral head or the glenoid capsule? Yes, no, Benedict? Are they present there? Okay, in this picture, can you see that there is any kind of a soft tissue swellings or the disruption of the contour of the cartilages? In this picture, okay, are there any disruption of the cartilages edges or the soft tissue edges of the humerus? And you can see here, is there any kind of signs of swelling as hypodensities along the soft tissues? No. So that is not a cartilaginous thing. Did you get it? And generally, unless and until there is a cartilage problem, generally a cartilage is not seen on an X-ray. A cartilage is best analyzed on an MRI. So whenever you are suspecting that there should have been a cartilage, but right now you tell me, if you are suspecting a cartilaginous injury, what is the disease that you might be thinking? What is that condition called as, Benedict? If you are suspecting a cartilaginous injury in this patient, what could be that condition called as? Soft tissue injury or cartilaginous injury, if it has happened, what do you call this condition as? Okay, have you heard of a term that is actually called as a frozen shoulder? Okay, okay, right. Try to find out what is a frozen shoulder. Okay, there is a condition that is actually called as a frozen shoulder. Okay, try to find it out. Okay, but that is the one that is actually causing the cartilaginous problems, Benedict. Okay, so then there will be a lot of clinical signs that are present, and generally a frozen shoulder is analyzed on an MRI. On X-ray, unless and until there is a lot of disruption, a lot of inflammation along the cartilages, you generally won't be able to recognize it on an X-ray. Plain film does not actually recognize unless there is a lot of inflammation. All right, I think that now, right now, it should have solved your problem. Generally, cartilage is also a stronger tissue, but it breaks. But cartilaginous disruption is not actually called as fracture. Okay, fracture is happening in a bone. All right. Well, since we came down in a fracture, since I talked about this, have you heard about a very, very weird clinical condition that is actually called as a penile fracture? Have you heard of this one? Fracture of the penis. It's only exclusively male condition, okay? Right? Well, the penis also gets fractured, okay? We'll talk about that later sometime, okay? Because that's a very interesting theory, okay? And yes, it all happens because of the women, right? Penis also gets fractured, but that fracture is different, okay? Cartilage also disrupts there, okay? That is a cartilaginous tissue there, right? Corporospongiosum, right? That is the one that is actually getting fractured there. It is a disruption of the musculature, or an erect penises actually causes penile fracture, but that one is different. Since you actually asked about the cartilage, so that's the reason I came up with the theory of penile fracture. We'll see that one later. Right. And so that is one. Sigmoid bones, I think what we were talking about before is that in anatomy, you should have learned that patella has got no such kind of a function. It is generally mentioned down in the anatomical textbooks as the patella as a vestigial organ. Have you heard this one before? Okay, it is a sigmoid bone. Sigmoid bone is a bone that is present inside a tendon, but in anatomy textbooks they also say that the patella is also a vestigial organ, right? Like the appendix has got no particular function, they also say in anatomical textbooks that the patella has got no particular function. But remember, your anatomy textbooks are wrong. Patella has a function in the knee. Yes, it actually prevents the hyperextension of the knee, and it actually also helps down in the locking mechanism of the knee. Okay, it has got a function. Okay, the textbook what you are actually reading hasn't been updated for so many years. Okay, so patella is not a vestigial organ. Patella is a functional organ. It has got a very, very important function in maintaining the posture of the knee. Okay, so it is a sigmoid bone, of course. A sigmoid bone is a bone that is present inside a tendon. Okay, and that one is actually also causes appearance of a fracture. Then accessory ossicles. Okay, accessory ossicles are the centers where the ossifications of the apophysis did not happen. Okay, well, the accessory ossicles, the best accessory ossicle that you will be actually known is about the fifth metatarsal of the foot. Okay, the fifth metatarsal apophysis is a very, very common area that you actually take up example. Okay, because that apophysis actually fuses only after 40 years. All right, let me show you. Just a second, please. Sorry. No. Just a second, I will actually get the picture for you so that you can understand what I'm talking about. Metatarsal apophysis. Okay, let me find out. Okay, nice. Okay, look at this picture, and you see here the fifth metatarsal apophysis is entirely different. See, there is apophysis. Apophysis is the place where the ossification center hasn't, the ossification hasn't appeared yet. Okay, so it actually happens. These are actually called as apophyseal or accessory ossicles. Okay, so they do not technically fuse because they do not ossify yet. And you see here, the best example we always take is the the fifth metatarsal, which ossification center, which actually the ossification of the apophysis of the fifth metatarsal only happens after 40 years. Okay, can everybody look the image I have sent you? Right? So you see here, apophysis is already marked and the fracture is already marked. You see here, that is how the apophysis or a fracture classification has to be done. All right. So best example is this way, but generally all of the bones have their own ossification centers and they heal at different times. Okay, I think right now we will actually take up a break here and then we will try to meet around 12 o'clock once again. All right, a break for 15 minutes and then we will try to continue the class. All right.